I'd like, first of all, to thank Dr. Joubert for inviting me to speak at the Emerge Rounds, and I hope you find the presentation informative. But more importantly, I think this may lead, or hopefully, to some dialogue and organizational changes that might improve what I think are some systemic problems in our institution. And I think you'll see as this evolves how that might occur. So it's really based on a case, and we can expand from that to discuss other things. My objectives really are to review vertigo and its localization. In neurology, just like real estate, is everything. And you can usually move from there to reach a diagnosis. To discuss and review the basilar artery ischemia and what diagnostic and treatment strategies we have for stroke or threatened stroke in the basilar artery territory, and to discuss involvement of the neurology on-call service, especially at the Vic campus, where we don't have as strong a neurological presence as we used to have. And together, maybe we can plan a strategy for timely and effective management of patients with acute neurological or potentially neurological presentations. So I was going to present this one case of a 45-year-old man who presented some time ago to the Emerge at Vic with vertigo, true illusion of environmental rotation, or true vertigo. He had vomiting and numbness, complained of numbness around his mouth, and decreased sensation in his left hand. He was found objectively to have some decreased feeling in his left hand, and had some nystagmus, but that was really it. And it was thought he had a benign sort of vertigo, and seemed to settle down a bit, and had a CAT scan, which was negative, and he was sent home. About 12 hours later, though, he was brought back in an unconscious state with what were thought to be seizures, but which were almost certainly decerebrate spasms, or recurrent extensor posturing of his upper limbs and lower limb extension. Because he was unconscious and apparently seizuring, he was intubated, sedated, and admitted overnight to the critical care trauma center and sedated with propofol overnight. And he had a subsequent scan. This was his initial scan of his head, which I think is essentially negative or normal. You can see here the basilar artery, which doesn't look especially any more prominent than do the other vessels around the circle of Willis that you can see. But when he came back 12 hours later, he had a repeat CAT scan of the head, and you can see on this scan that the basilar artery is showing up much more than it did before. The radiologist interpreting this didn't really appreciate this difference, but commented that he thought there was something a little weird about the temporal lobes, that they looked not quite right, but wasn't very clear what was going on. So anyway, he was admitted, and we saw him the next day, at which time he was awake. This can be sometimes a difficult thing to sort out, but he truly did wake up, open his eyes, and had vertical eye movements, and would blink his eyes to command, could open and close his eyes to command. So he clearly was aware and responsive in this sense. But he had no horizontal eye movements. The eyes didn't move laterally at all. He couldn't voluntarily move his jaw or lower face or tongue, and he was essentially quadriplegic with upgoing plantar responses, and he was making these decerebrate spasms similar to what he had the night before. So does anyone know what this syndrome is called? Yes, locked-in syndrome, that's right. This is a classical appearance of a locked-in syndrome, and the patients are awake and they have vertical eye movements. It was described in the Count of Monte Cristo, actually, with a corpse with living eyes, the person who could move his eyes up and down, didn't really say that, but was otherwise mute and quadriplegic. And the lesion's almost always in the basis pontus, which eliminates the sixth nerve function. Cortical bulbar and cortical spinal tracts are affected. And so the person is effectively locked in terms of any motor response, except for these eye movements. They often have preserved sensation, and they're awake and aware. So this was his MRI scan, which we obtained shortly after, and shows the caudal midbrain. This is a diffusion-weighted image, and anything that looks bright has ischemic damage, really. So you can see this area of the brainstem is showing up quite brightly and affecting the cerebral peduncles. It's really almost at the pontine junction with the midbrain, and some of the tegmentum also is affected. And lower down in the pons, virtually the whole pons is affected, except for a little rim around the outside. But he was nonetheless still conscious, and the third nerve function was reasonably good for vertical eye movements. And the dorsal part of the seventh nerve must have been okay too for the eye blinks. And he has a couple of little ischemic lesions in the occipital areas posteriorly. His MRA shows the circle of Willis, the internal carotid arteries coming up, anterior cerebral artery, and these are the vertebral arteries come up, and you can see their junction just where they join to form the basilar artery, but not much beyond that. Similarly, you can see the posterior communicating arteries forming the top part of the basilar, but really the whole basilar is occluded, or not showing any perfusion. So we thought this was probably a mid-basilar kind of occlusion with thrombus that just propagated to virtually occlude the whole thing except for the very rostral part. But the posterior cerebrals were spared. And so the problem was, I think, that vertigo with presentation can be a very difficult thing. By itself, it isn't very localizing at all. But it was a clue that this man was having a stroke in the basilar circulation. So we'll just discuss a little bit about vertigo. Vertigo is by definition an illusion of movement. And that can be either a sense of environmental rotation or spinning sensation where things seem to be moving around like on a merry-go-round, or it can be just an environmental tilt. Any kind of movement that's an illusion of movement that isn't real can be considered vertigo. People often say they're dizzy, and we wonder, well, is that vertigo or not? And people can mean all kinds of things by dizzy. They can mean true vertigo. They can mean a blackout. We had a person the other day who was really describing diplopia and called it dizziness. They can mean they're just lightheaded or faint feeling, or sometimes people even, or say they have some impairment in their consciousness or their vision or something. So it's a very vague term, dizziness. Vertigo is more precise, but you have to be sure it is truly vertigo. And any kind of illusion of movement, I think, is fair enough to call vertigo. It's important to recognize, and I think there's a lot of folklore about dizziness, that we have to always crank their head around and see if they have increased vertigo and nystagmus when they're presenting. And anybody who's dizzy, truly dizzy or vertiginous, I should say, is going to be aggravated by head movement. It doesn't prove they have benign paroxysmal positional vertigo if they develop increasing nystagmus and vertigo with the head movement when they're already dizzy or vertiginous. So I'll come to describe a little bit more about that Dix-Hallpike maneuver later. But the real issue is whether the problem of vertigo is in the peripheral part, that is in the vestibular nerve or in the semicircular canals or utricle, or is it central, that is, in the brainstem or at central connections of the vestibular system? So that's the problem. That's the thing we have to sort out. And these are some of the different peripheral causes of vertigo. There's the benign paroxysmal positional vertigo, which is very common, often follows head injuries or may just occur spontaneously. Vestibular neuronitis, which is the kind of more protracted type of vertigo, quite miserable. Labyrinthitis, a similar kind of thing. These are almost inseparable, really. Meniere's disease, in which there are auditory symptoms as well as vestibular symptoms, usually echoing or tinnitus, and followed by decreased hearing on the affected side because it's a problem with the membranous part of the inner ear. Or trauma certainly can cause vertigo with damage either to the inner ear or auditory nerve. Acoustic neuroma, growth starting initially on the vestibular part of the nerve, and often vertigo is the first presentation, followed then later by auditory symptoms. And migraine sometimes can give a peripheral type of vertigo. The main central causes are vascular, that is transient ischemic attacks or basilar ischemia, or occasionally lateral medullary syndrome. Multiple sclerosis, the root entry zone of the eighth nerve is often affected with MS. Migraine can also be central as well as peripheral, and tumors that directly involve the brain stem. But these are fairly limited, and I'll maybe just go through some description of how to differentiate them. If the vertigo is extremely brief, they're just lasting a few seconds, it's almost always peripheral rather than central. That's a sort of rule of thumb. And benign paroxysmal positional vertigo, the vertigo is usually just very short-lived when the person turns the head or rolls over in bed. They get vertiginous for a few minutes at the most, and then it settles down. But it is typically brief and lasts just a few seconds to a minute. If it lasts several minutes, it can be migrainous vertigo or vertebro-basilar TIAs, sometimes strokes, that go on for minutes, or hours or longer. Meniere's disease, vestibular neuronitis, labyrinthitis, multiple sclerosis, or brainstem stroke. So the typically very brief vertiginous episodes, we don't worry too much about those. If they're very brief, and if that's the only thing they have, it's almost always peripheral. Another bits of clues to localization are if they have auditory symptoms, it almost always implies the problem is peripheral, because the auditory and vestibular pathways peripherally, that is in the inner ear and along the eighth nerve, travel together. Once they get in the central nervous system, the auditory and vestibular pathways are very separate, and they almost never does central cause the combination of auditory and vestibular symptoms. If the vertigo is accompanied by anything else, think of it being central. If it's accompanied by visual symptoms, diplopia, flashing lights, numbness, weakness, trouble speaking, dysarthria, whatever, think central. That is, I think, a good rule of thumb. Almost everybody who's vertiginous may experience nausea and vomiting, and it isn't particularly helpful for localization at all. If the person goes on to loss of consciousness, it's usually kind of a secondary thing from a faint. It occasionally has been described with seizures, but it's very rare. They usually occur in the vestibular area of the brain, or sometimes in the frontal lobe where the eyes are driven to one side, and the person may experience a brief vertigo before passing out and convulsing. But it's not very often due to vertebro-basilar transient ischemic attacks. It does go up and supplies the thalamus, and we've had a few patients who've lost consciousness because of thalamic infarcts, but that isn't usually transient. It's more long-lasting. So brief loss of consciousness isn't too helpful. It's often just a faint. So those are some additional helps in localization. So some of the signs with vertigo are in benign paroxysmal positional vertigo, or BPPV, the Dix-Hallpike test, which you're probably familiar with, in which the person sits on the bed, their head is, head is turned to one side and downwards, and you watch for, there's usually a latent period of 10 seconds or so, and then they develop a rotatory nystagmus, not purely horizontal or vertical, but rotatory, kind of a twisting nystagmus. And that subsides usually in a few seconds. You sit them up, they get vertigo again on sitting up, and the nystagmus occurs in the opposite way. If you do it again, the vertigo subsides, and the nystagmus subside with each time you do it, until it eventually just goes away. So that habituation is very typical for benign paroxysmal positional vertigo. And as I mentioned, the vertigo is brief, just a few seconds usually. And they can certainly barf with this too, of course. They can get quite nauseated. So, and as I mentioned, any acute vertigo is accompanied by, is aggravated rather by sudden movement. So it isn't very helpful at testing somebody in the acutely vertiginous state by doing the Dix-Hallpike. It doesn't really tell you. They'll all feel miserable when you do it, and it isn't particularly useful at that time. Now, if the person has a central cause, usually a brainstem cause for the vertigo, they have nystagmus that is direction changing. It has a fast and a slow phase, and the fast phase is in the direction of gaze usually. If they look to the right, they'll have a right beating nystagmus. If they look to the left, they'll have a left beating nystagmus. They may also have vertical nystagmus, which is always a brainstem sign. And they may have, in addition to the vertigo, they may have ataxia, true ataxia. You can test it by having them close their eyes and touch their nose. And that'll be out of proportion to their vertigo. People with vertigo often have trouble standing. They look ataxic, but if you test them with the heel-shin test and with the touching their nose and so on, they usually don't have true ataxia. They can have a little bit of past pointing, but not much. If they have a gaze palsy, they're unable to look to either side. That's always a sign of a brainstem lesion as a rule in this situation. A skew deviation, which is a vertical malalignment of the eyes, or one eye is above the other, is again a sign of brainstem involvement of the medial longitudinal fasciculus caudal to the sixth nerve, or any focal signs like weakness on one side or other, or trouble moving the tongue, sensory loss, etc. So those are the best clues we can think of anyway for helping localization. And there are several different vertebro-basilar artery syndromes. There's the top of the basilar syndrome, which is kind of a catchy phrase, but this is almost always due to an embolus that travels up the basilar and occludes the distal basilar, the posterior cerebral arteries. So these patients have ischemia in the territory of their posterior cerebral arteries, which go to the medial temporal lobes, the occipital lobes, so they often have flashing lights or loss of vision, or and they may, because of the involvement of the posterior cerebral that can supply some of the rostral midbrain, they can have some other symptoms as well. If it goes up to the thalamus, they can lose consciousness, but that's pretty uncommon. Mid-basilar artery symptoms, which are due usually to ischemia here with these little perforating arteries being affected and some long circumferential arteries being affected, they tend to have symptoms that as you might expect with the weakness on one side or other, which is more typical in this patient's presentation. If they have ischemia affecting the sixth nerve, they will have diplopia. If the cortical bulbar tracts are affected, they'll have dysphagia and trouble speaking and swallowing, of course. And the long circumferential vessels, they may have, they could have other dorsal symptoms, including vertigo. The proximal basilar, you can get most often the lateral-medullary syndrome with infarction in the posterior inferior cerebellar artery territory. Or sometimes the anterior spinal artery, which isn't shown here, can lead to infarction of the pyramids, and you can have quadriplegia in association with the lateral-medullary syndrome, in which they have a Horner's syndrome, ipsilateral ataxia. They can have vertigo, sensory loss on the opposite side of the body, that sort of thing. So these are the different syndromes that can occur in this vertebro-basilar territory. So when the basilar artery gets occluded, this is not the most, it's not a common form of stroke, and it only accounts for about 20% of ischemic strokes. So the studies on this system have not been as good as studies on the carotid system. And the onset and symptoms are highly variable, and that's why it can be confusing and difficult to diagnose cases early on. The CT, as shown here, is very insensitive to basilar occlusions. It's insensitive to anything in the posterior fossa, so don't rely on it. It isn't very good. And if you're looking just for a hyperdense basilar sign, you may or may not see it. So it isn't very useful. So if you're really thinking of a basilar stroke, don't bother with a plain CT of the head. Get an MR or MRA or a CT angiogram. And you may need to get a neurological consult to help you get that, but that's really where to go, I think, and don't waste time with an ordinary CT. For no treatment of basilar occlusions, they almost all do badly. The other treatments that are thought to be effective are thrombolysis, either intravenous or intraarterial, or anticoagulation with heparin, followed by Coumadin, or antiplatelet drugs. They have used, some people have used anyway, mechanical thrombectomy or stenting in the basilar system as well to try to overcome the acute occlusion. So there is one good study, and it isn't all that good really, because it wasn't a randomized control study. It was just a prospective study, but it included quite a few patients, multiple different countries, based primarily in Holland, called the BASIC study, or Basilar Artery International Collaborative Study, that was published in 2009. There were 592 patients with basilar occlusions who were studied, and they were just followed prospectively. It was an observational study, not a controlled study, and it was kept track of when they presented and what type of treatment they had from the years 2002 to 2007, and the outcome at 1 year was determined as the final outcome using the modified Rankin scale, which goes from 0 to 6. 0, no symptoms. 1, they're able to do their previous activity despite having some minor symptoms. 2, they can do their affairs but not all previous activities. 3, they're able to, they need some help in doing things, but they can walk unassisted. 4, they're disabled, need assistance for needs in walking. 5, they're bedridden and incontinent. And 6, they're dead. So 4, 5, and 6 are considered to be poor outcomes, understandably. So, and the others are stratified as being relatively good outcomes. So that was sort of the way this was set up. This is the groups. These are the whole group of 592 patients. The 183 were treated with arterial thrombolysis, intravenous thrombolysis, and 121 in no, I'm sorry, this is antithrombotic therapy. This is platelets, antiplatelet drugs and anticoagulants, sorry. This is intravenous thrombolysis, and this is intraarterial thrombolysis, 288. But if you notice the time to treatment here, it's quite variable across these three groups here. And the ones, there's a fairly high percentage of those treated with intraarterial therapy who, sorry, with antithrombotic therapy who were a bit late in getting their therapy. But the investigators tried to adjust for this, and in their final presentation adjusted for the time of presentation. So this is the outcomes. This refers to the mild and moderate deficits at onset, and these are the outcomes. And these are the patients who presented with severe deficits. And you can see we were saying that 4, 5, and 6, that is, are the severely disabled ones. That accounts for almost over 70% of the ones who present with severe deficits are left with very poor outcomes. While those who present with mild to moderate deficits, at least half of them, a little more than half of them, do well. These are, in B, it's the patients who present with mild to moderate deficits, and there isn't a great deal of difference between antithrombotic therapy, intravenous thrombolysis, and intra-arterial thrombolysis in terms of their outcomes. Perhaps a little bit better, surprisingly, for intravenous thrombolysis and antithrombotic therapy compared to intra-arterial therapy. I think there's probably some selection went on here, but that might account for why this group seems a bit worse, because they probably were worse on presentation. But that's speculative. And then if they present with severe deficits, none of them do well. You can see antithrombotic therapy here, only 15%. Intravenous thrombolysis, it may be about 25% or so. And intra-arterial therapy, only, maybe 17% or so would do well, and the rest have severe disabilities. So it pays to try to get them and treat them early. They will have a better chance of a better outcome. But it's not a perfect study by any means. So the basic study, the trial was not perfect at all and suffers from the problem of not being randomized and just observational. Almost certainly there was some selection going on in terms of the types of therapy they were given. But in contrast to the carotid territory, anticoagulation seems to be often effective in basilar thrombosis, and it could still play a role. And that's the old, long before this study came along, that was sort of party line, and that was done by the older strokeologists like Miller Fisher and J.P. Moore, who would give them heparin and put them head down and hope they would perfuse their brainstem better. But it seems that it does have some effectiveness. Basilar occlusions, all of them, it's a dangerous thing, and they do have a high mortality and morbidity. But there is some evidence anyway that if patients are treated early with mild disability, they may do better. Our patient, because of the fact that he didn't present as a sudden, bam, maximum onset kind of presentation like a top of the basilar occlusion would, and based on his symptoms and findings, probably had a mid-basilar thrombotic type, not embolic stroke, and progressed from there. He didn't have a lot of arterial disease on his other images, and I don't know quite why this occurred, but and he did have some risk factors of smoking and hyperlipidemia. Earlier diagnosis and treatment could have led to better outcome. But I think when we look at this issue, that I think that we need to try to overcome any systemic problems here. And it wasn't any one person's problem with this case. I think there was a systemic problem. It was, there was a problem with communication. The radiologist could have done a bit better, I think. And the problem with neurology involvement, especially as a problem at the VIC, where there's only one neurology consultant on at night, and that person is based at UH and seems to have to stay there because the strokes all come there. And so we have to be there within 5 minutes of the stroke arriving, and it's hard to be here and to cover a stroke at the UH. So it's a problem. So I don't know what the best suggestions, best remedy for this is. And I've talked to Mike Nicole about this, and Dr. Joubert and I have spoken to Mike, and we've talked among each other, and I know there's been an email exchange about these sort of issues. And I don't know, but these are some things that came to mind. I think that the neurologist on call should be available for you, and if there are some problems that come up, and as was mentioned, you have a ton of vertigo patients here, and the Emerge department actually does a great job with handling a huge volume of cases and does it really well. But when there are some specific problems, don't be afraid to call, and we can try to resolve things over the phone. Often that's good enough. We can see the scans through our PACS system at UH, and we can try to sort things out. We can lobby for getting an MRI or a CTA if we need to. Some people mentioned the transfer from Vic to UH Emerge often isn't necessary, and it takes time for that. And stroke time is of the essence. So I think that we can try to do it here, but we need to have more neurological interaction, I think. What we did a while ago, we tried to have a stroke network, and we involved Chatham and some other centers, and it seemed to work fairly well. In fact, I thrombolyzed a person in Chatham Emerge with the video hookup and the PACS system that we could see their scan, and we could look at eye movements, we could look at the whole thing. It worked, I thought, very well, but the whole program was stopped because of concerns of medical liability on a part of the neurologist, and I think we were really chicken to not try to resolve this better, and I think we should find a way around this and not worry so much about the liability issues. Some things that have been done in the States are having a hospitalist or a nighttime neurologist called a nocturnist, kind of an unusual term, but a person who works at night to service the facility. And this person, and I wondered about maybe some of the community neurologists serving in this role, perhaps, or we could do it on a rotational basis. And in the US, they do it with, they're dedicated to do this for a period of time. They're given perks, extra perks. I don't think just extra food or anything, but extra money or something, and to stay up and work through the night. And these are just a few ideas, but I think you might have better ones. And but we have to find a better way of trying to deal with this so we don't have patients who have strokes and without some neurological input into their care. So I'd like to stop at that point and see if there's any comments or questions.